Yeah, I can see the slide. Yeah, that's good.
It's okay, sir. Okay.
Yes, perfect.
Okay, sir. I'll stop the share, sir.
Sure.
Okay, sir, we are already live.
Please open the session.
Sir, you will be giving the talk, and after that, I have to give the.
Yeah. That's
Okay.
it. You will take about 15-20 minutes?
Yes, sir.
Yeah,
If I exceed, just by any chance I exceed, you just tell me. I'll wind it up fast.
Okay.
Right.
So I have just checked with Raghu, sir. He will be joining, sir, now, shortly.
We are actually, what is happening is we are having that mitral valve conference this weekend, no? So
I know.
a lot of firefighting.
Yeah, I know. It's so difficult to manage. It's easy to manage a CME, but if it's a workshop, it becomes very difficult. You have to look after so many things.
There are many things that is.
2 more minutes to go. Is it open to the audience to join?
Yes, sir. They have joined. They're joining already.
As is very, no, Dr. Raghu has joined.
Raghu, namaskar.
Namaskar. Now you're muted.
Yeah, morning, sir. Good morning, everybody.
Good morning. Namaste.
Good morning, sir.
Good morning, sir.
Good morning, Rajiv.
So as it is planned, once the introductory video is played, Clearnet will introduce their company, and then I will invite Dr. Prasanna Sinha and Dr. Raghu. Then I'll proceed. And then at the end of my talk, Dr. Prasanna will give the surgical input, and then we'll start the discussion. And towards the end, they say again one more video is there.
Okay, sir. It is sharp 9 p.m. 9 a.m. So should we start?
Yes, please.
Good morning and a warm welcome to all the dignitaries present here. Myself, Rupsha from Clearnet, assigned as a station assistant to ensure a seamless experience. Clearnet stands as India's most relied upon digital platform, offering a multitude of imaging services exclusively for doctors. It is with great pride that Clearnet is the digital partner of this event organized by Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Forum of Cardiac Anesthesia, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Healthcare Foundation. And the topic of today's session is echocardiography for aortic valve repair. So please allow me some time to play a short video.
Good morning to everyone. Thank you for joining us. Today is the 19th of May, 2024. We are having the Sunday TEE breakfast session with the experts today. And this is being conducted under the auspices of Indian College of Anaesthesiologists, Indian Association of Cardiothoracic and Vascular Surgeons, Global Heart Care Foundation, Global Intensive Care Symposium, and International Society for Cardiac Ultrasound. We are grateful to all the participating societies for this invaluable support. And we have been doing this more or less incessantly on every Sunday between 9 to 10 a.m. in the morning. And it has become a popular event on Sundays. And today I have Dr. Prasanna Simha from Jayadeva Institute of Cardiology. He is a well-known cardiac surgeon with extensive experience in valve repairs. I would like to welcome to this meeting.
Namaste.
Dr. Jaisimha, would you like to say hello to the audience?
Hello. It's wonderful to be able to interact with, because ultrasound and echocardiography are very dear to my heart. Thank you. It's a cornerstone of valve repairs.
Yes. Thank you, Dr. Prasanna, for being with us. Next is Dr. Raghu, who is extensively experienced in echocardiography interpretation and assessment of aortic and mitral valve, actually all valves. He does all complex cases, and he is a value-added faculty in this seminar. I request him to say hello to the audience. Your
Muted.
mic is muted.
Hello to everybody. Thank you for inviting me for this session, sir. Thank you so much.
I also would like to invite Srinivas and Rupa. They are present in this meeting. We look forward to their valuable input at the end of the session. And to begin with, I will start the sharing the screen. The topic is aortic valve repair. How do you assist the aortic valve for repair in cardiac surgery? So I'm just sharing the screen and I hope it comes up. And I pray that all the videos will run, whatever is there in my armamentarium. To begin with, David et al. Described the aortic valve repair for the first time in 1992. It's about close to 30 years. Since then, aortic valve repair has become increasingly used for the treatment of aortic regurgitation. It can be done in young and middle-aged patients who have aortic valve dysfunction and those with aortic root dilatation, whether it's congenital malformation such as bicuspid or unicuspid valve, or it's acquired tri-leaflet aortic valve pathology. The advantages of aortic valve repair is that it avoids the long-term risks of anticoagulation, allows the growth of the person, especially if it's a child or adolescent, and postpones aortic valve replacement, and leads to excellent mid and long-term effects at expert hands in centers which routinely do this. We'll just quickly go through the fundamental anatomy. I'm just trying to change the slide. Fundamental anatomy of the aortic root. The aortic root is defined as that portion of the aorta that supports the leaflets of the aortic valve, delineated cranially by sinotubular junction. The sinotubular junction and caudally by the ventriculo-aortic junction. Kindly note the terminology is used. This commonly colloquially known as the aortic annulus, but it actually is the ventriculo-aortic junction. And we have the sinuses of Valsalva, which are just outpoaching at the root of the aorta, which houses the origin of the coronary arteries. And the function of the sinus of Valsalva is not only to act as a reservoir of blood during diastole, but also to prevent the contact of the aortic valve with the wall of the aorta, such that there is no friction between the aortic valve and the aortic wall, during diastole. So these are the two important functions of the sinus of Valsalva. The figure on the right side shows the schematic representation of the aortic root, which is opened longitudinally. There are interleaflet triangles. These are the interleaflet triangles. The commissures, these are the commissures. This is the attachment. Please note that these commissures almost reach the sinotubular junction. This is the sinotubular junction. They almost reach the point of the sinotubular junction, these commissures. And we have the origin of the coronary arteries, right and left. And on the non-coronary, there is no opening for the coronary artery. And you have the valve leaflets. The nadir of the leaflet almost reaches the aortic annulus, which is colloquially called, but actually it is the ventricular aortic junction. Coming to the echocardiographic assessment, before that, we have basically 4 types of aortic valves. The commonest is the tricuspid aortic valve, which is normal. It has 3 commissures. And we have the bicuspid aortic valve, which is a congenital anomaly present in about 1 to 2% of the population. It has 2 commissures, and it may also have 1 non-functional commissure. And we have more rarely unicuspid or quadricuspid valves, which have 1 functional commissure or 4 functional commissures respectively. Coming to the aortic evaluation, one of the most commonly used views to look at the aortic valve is the aortic valve short axis view in the mid-esophageal window. In the mid-esophageal window, the multiplane angle is rotated about 40 degrees. When you see the aorta in the middle in the form of a Mercedes-Benz sign, we have the left coronary cusp, right coronary cusp anteriorly in the far field, and the non-coronary cusp, which is always in relation to the interatrial septum. If you look at the moving image, this is the actual real-time depiction of the aortic valve in the short axis view. We have the left atrium, interatrial septum, right atrium, tricuspid valve, right ventricular body, right ventricular outflow tract, pulmonary artery, and the aortic valve in the center. The leaflets are usually symmetrical inside, 3 of them symmetrical. Sometimes, even in normal situation, one of them may be smaller than the other. The left, right, and the non-coronary cusps are seen in this view. And if you turn the angle to about 120 to 140, we get the long axis view of the ascending aorta along with the aortic valve long axis. And this is a schematic representation. The multiplane angle is rotated to about 130 degrees. We have the interventricular septum, the left ventricular outflow tract, the anterior mitral leaflet, the posterior mitral leaflet, left atrium, and the right coronary cusp in the far field. And this can be non-coronary cusp or left coronary cusp, depending upon the orientation of the probe and depending on the structure which is actually cutting. And usually we use the biplane mode to know which cusp is being cut in this view. This view is very important not only to look at the morphological features of the base of the root of the aorta and the aortic valve, but also to look at the functional aspects of the valve. And this is the actual picture. You have the right ventricle here in the far field, the interventricular septum, the aortic and mitral valve. The measurements which are made in this view are shown in the next slide. We have the normally the aortic valve cusp coapt in diastole above the annular plane. This is the annular plane which I actually mentioned is the ventricular aortic junction. And you have the coaptation occurring in diastole. The function of the aortic valve is to prevent blood flow from the aorta to the ventricle during that's the most important thing, and during which time the coronaries get filled blood and myocardial blood supply is maintained during that point of time. These are some of the measurements which are made. I'll be showing it to you in an actual echocardiography picture. This is the diagrammatic representation. We have the geometric height, which is actually the whole length of the valve leaflet, whether it is right, left, or non-coronary. Then we have the commissural height, commissural length. Sorry, this is the coaptation height, and you have the commissural length from the point of annulus to the tip of the leaflets. And next view we normally use is the transgastric views. We have, this is the transgastric long axis window in the mid papillary view of the left ventricle. If you increase the angle to about 120 or 110, we would see the transgastric long axis view with the aorta in the far field on the right side, the left ventricle, the mitral valve here, the anterior leaflet and posterior leaflet of the mitral valve, and the LVOT. And this view is important because sometimes if we do not get the Doppler alignment, or we are not able to get the good picture of the deep transgastric view, this can be used to measure the Doppler velocities across the LVOT aortic valve, because this view, in this view, the echo beam is almost parallel to the blood flow, and this is useful for the proper alignment of the Doppler beam. This is the picture, the aorta on the right lower side, the left ventricle, the mitral valve here. And next view is the deep transgastric long axis view, where you introduce the probe further into the stomach at 0 degrees angle of the multiplane, and then acutely antiflex and get the aorta either in the center or towards the right of the image. And here again the Doppler beam, which is passing from here, this is the probe here, which is passing almost parallel to the flow of the blood, and hence it's very valuable view to get the Doppler velocities measured across the aorta and the LVOT in patients whom we are doing the echocardiographic examination. This is the view of the deep transgastric view. This is the aortic valve here, the left atrium. In this view, in the using TE, the left atrium can be fully seen. If you are looking at the LV volumes, you might want to use this view to get the LA volume. I'm sorry, it's LA volumes, especially in patients whom we want to look at the diastolic function. Then we have the mid-esophageal 5-chamber view, which is obtained at 0 degrees from 4-chamber. If you withdraw the probe to about a couple of centimeters, you get the 5-chamber view. It's 5-chamber view is nothing but a 4-chamber view where you can see the LV in the aortic valve in the near field of the screen. Next picture I will be showing is the picture of a bicuspid aortic valve. This is bicuspid aortic surgical picture in one of our patients, and this is the quadricuspid aortic valve. And the valve type is defined by the number of the cusps based on the number of functional commissures. Please note that it is the functional commissures which is important, which extend up to almost, as I said previously, to the sinotubular junction. Number of functional commissures determine the type of valve you're dealing with. This is the normal tricuspid aortic valve with 3 cusps and 3 commissures, and the functional commissures extend up to the sinotubular junction. And here we have 2 types of bicuspid valves with no raphe. When you call it 0 raphe, here there's no raphe seen. The 2 cusps of the aortic valves are seen, and this picture shows again a bicuspid valve with a raphe in between the right and the left coronary cusps. And here we have the unicuspid valve where there are 2 non-functional commissures and 1 functional commissure. If you look at the normal valve, there are 3 functional commissures, and in the bicuspid valve there are 2 functional commissures with or without a non-functional commissure. And in the unicuspid valve, you have only 1 functional commissure, and the 2 other commissures which may be present are non-functional. And what are the measurements? Actually, I'll be showing it to you in the next few slides within the time permits. In the short axis view 40 degrees, 40 to 60 degrees. We look at the morphology of the aortic valve, especially with regard to the unicuspid, bicuspid, quadricuspid, or tricuspid. As I said, tricuspid is the commonest valve we encounter. That is actually normal. And look at the cusp motion, whether it is restricted or moving fully and freely. And if you put the color Doppler, you can see the jet, origin of the jet, and how is it going, and what is the commissural orientation. This also I'll be dealing in the next few slides. Coming to the long axis, what is the aorta phenotype? Is the sinotubular junction dilated? Is the proximal ascending aorta dilated, or the sinus of Valsalva dilated, or the aortic root is dilated? That these four types, or the aorta is normal. These are the phenotypes of the aorta which we look at. And again, you look at the cusp motion, whether it's freely moving, whether it is fully opening, and with color Doppler jet, is there any jet? Color, regurgitation jet. What is geometric height by measuring the whole length of the leaflet, and what is the effective height, and what is the coaptation length. Say all these parameters can again be measured in deep transcatheteric view, especially this view will be useful when you're coming off bypass because of the acoustic shadowing, especially if you use a graft replacement of the ascending aorta. The shadows may prevent you from measuring these parameters in the other views. So here again, you can use the Doppler alignment advantage to measure the gradients. There are 6 to 7 steps when we actually look at the valve just to assess whether the valve is repairable. T is particularly adapted to identify lesions that are suitable for repair based on valve and root anatomy, and looking at the aortic valve mobility and the mechanism of aortic regurgitation. The main advantage of echocardiography intraoperatively is that we are doing this in real time. So these 6 or 7 steps are mentioned here. What is the valve phenotype? That is it tricuspid, bicuspid, unicuspid, or quadricuspid? What is the root phenotype? Is the ascending aorta dilated, or is sinotubular junction Valsalva, or the annular dilatation? What is the degree of aortic regurgitation? What is the mechanism? What is the quality of the aortic valve tissue? And what are the measurements, which we will look into that shortly? And where are the coronary arteries? Where are they normally located? And how is the pulmonary valve? All these things have to be assessed when you're thinking in terms of aortic valve repair. The phenotypes I already mentioned. I think I can skip this. In tricuspid, you have 3 functional commissures. In bicuspid, you have 2 functional commissures. The small non-functional commissure may be present. In unicuspid, there's only 1 functional commissure, 2 non-functional commissures. The aortic valve phenotypes these are the tricuspid aortic valve, bicuspid, unicuspid, and quadricuspid are shown here. The true end-fast view of the aortic valve is shown. This is the tri-leaflet valve. Once you see the identify the level of coaptation, if you withdraw the probe a little bit, you can see actually the commissures, and this will be useful to measure the distance between the annulus to the commissures to be able to know the commissural height, which is again important. You also can determine the commissural height of the functional commissures as well as non-functional commissures. And also you can measure the coaptation height. For example, here you're trying to get the coaptation height in patients who have aortic valve when you're assessing the aortic valve. The next step is the determination of the root phenotype. As I said, whether it's normal aorta, root is dilated, whether it's at the level of the ST segment. STJ, that is sinotubular junction, not ST segment, sorry. Sinotubular junction, and is it at the level of the sinuses or at the aortic valve? The standard measurements which are done or mentioned here, the aortic annulus measurement is usually done is as per the AAC recommendations. AACE recommend, not AAC, AAC recommendation, that the American Society of Echocardiography recommend the aortic annulus is determined or measured during systole because the largest diameter of the aorta can be measured here. Whereas for the other measurements, for example, at the level of the sinuses or sinotubular junction or the ascending aorta, it is in the diastole. Because it is in this, at this point of time, the blood is contained and the maximum diameters can be measured. Using multiplanar reconstruction, additional information can be looked at. For example, is the aorta circular or it is not really circular? This is also called as ellipticity index. Please do not confuse this with eccentricity index or sphericity index. This is ellipticity index, where the one diameter is greater than the other. Usually it is circular. And then you also can withdraw the probe and look at the symmetry of the sinuses and the sinotubular junction, and at the ascending aorta level also you can measure and see if it is symmetrical in shape or there is some dissymmetry. Coming to aortic regurgitation, that is first is about the phenotype of the aortic valve, second is the phenotype of the aortic root, third is the aortic regurgitation. We have to look at the aortic regurgitation, what is the grade. And this is well known to most of the cardiac anesthesiologists. Just to complete, the vena contracta width is greater than 6 millimeters, or the vena contracta area greater than 50 square centimeters. Regurgitant orifice area greater than 30 millimeters square, or 0.3 square centimeters. Regurgitant volume greater than 60 ml per beat, or regurgitant fraction greater than 50%, qualified to be called as severe aortic regurgitation. So in both tricuspid and bicuspid valves, you can look at the jet, but because in under anesthesia, the loading conditions are different. So these assessments must be done in awake OPD street conditions, where the actual blood pressure, patient's normal blood pressure, and loading conditions can be ensured, and you can make precise estimations of the grade of aortic regurgitation. Central and eccentric jets are shown here. Eccentric jets invariably mean that aortic regurgitation at least moderate, if not severe. And you can use PISA method to quantify the aortic regurgitation. The deep transgastric long axis view is used here. This is the deep transgastric view. You are seeing the jet across the regurgitant orifice area. If you reduce the Nyquist limit about 40 centimeters per second, you can get you can straight away calculate the PISA radius and the effective regurgitant orifice area from that. Usually R squared by 2 is the regurgitant orifice area. In this case, the PISA radius is 0.7. This is the PISA radius shown in red color here. And then we have the vena contracta is shown as 0.5, and regurgitant orifice area is 0.34 square centimeters, and the regurgitant volume is 79 ml as per the PISA calculation. So it quantifies to be the called as severe regurgitation. Coming to mechanism, there are three important mechanisms. One is the cusp movement is normal, but there is regurgitation. Usually the jet is central, or the cusp is prolapse, that is excessive motion. And usually the jet is in the opposite direction of the prolapsed aortic valve leaflet, and it may be cusp may be retracted and restricted motion, where the jet is usually towards the side of the abnormality. Elcori has classified the aortic root, aortic regurgitation mechanism in patients who have this valvular disease. So you have the type 1, type 2, and type 3. Type 1 is because of dilatation. The cusp movement is normal. It can be at the level of the aorta. Aorta is dilated here, or it can be at the level of the sinuses. Sinuses are dilated here, or it can be at the level of the annulus, annular dilatation, or there may be leaflet perforation. All these lesions are amenable to repair procedures. I will come to that again later in the presentation. I have 4 or 5 minutes more. I'll try to finish it off before I hand over to Dr. Prasanna. And the type 2 is the excessive motion, and type 3 is because of the wrist. This is the type 1 where there is where the 3 different types are shown here. Ascending aortic dilatation, root dilatation, and the dilatation of the ventriculo-aortic junction. And the type 2 is because of the valve prolapse. For example, in this case, the right coronary cusp is folded and prolapsing, leading to the eccentric jet. And you have the type 3 here, where there is restriction. Sorry, this type 2. I'll see the type 3. This is the type 3. There is restriction of movement of these 2 leaflets. Only one leaflet is moving. So there is failure of coaptation because of restricted movement. Sometimes these mechanisms may be combined. The aortic root may be dilated. In addition, there may be restricted. These are some of the specific measurements of the leaflet geometry. This is where we are measuring the orientation of the commissural commissures. Commissural orientation is measured here. Then you are measuring the effective height, and also you can measure the coaptation height. Then you are measuring the leaflet margins, length of the leaflet margins, and individual leaflet height, that is the geometric height. This is the left coronary cusp being measured, the right coronary cusp being measured here, and then the non-coronary cusp being measured here. Next, we look at the tissue quality. How good is the tissue? Is it thin? Does it curve during systole and bend during diastole? And also look at the grading of the calcification. How much is the calcification? The 1 is no calcification, 2 is small specks of calcium, 3 and 4 have more calcification, and you in general, patients who have calcification to the level of 3 and 4 are not suitable for repair. Then you look at the coronary anatomy. Is there any abnormality of the coronary sinus? For example, in this case, the left circumflex and the left anterior descending or arising separately. So this has to be taken into consideration when you're looking at the repair procedures, especially involving the aortic root. Post-repair assessment, you can actually deliver before you are coming out bypass, deliver cardiac pressure at the root and see if there's any regurgitation. As is shown in this picture, you can use echocardiography even before coming out bypass and then assess if there is any regurgitation significant. And after you come out bypass, you measure all the measurements and see what is the grade of MR and is it central or eccentric? What is the coaptation distance? If there is more than a mild AR or eccentric AR, low coaptation, that is the coaptation at the level of annulus or even below, or short coaptation length less than 4 or 5 millimeters, this may not be accepted. And if there's a gradient across the vertebral, again, you may not like to accept it in that particular case. Before I conclude, the repair of the aortic valve can be considering all valve phenotypes, all root phenotypes, and all AR severities. Mechanism of AR type A, B, C, D, and type 2. Type 1, A, B, C, D, and type 2 can be considered. Type 3 is usually not considered. The cusp should be flexible with no systolic restriction of the cusp motion, and the calcification less than 2 or equal to 2. And the geometric height of the valve should be greater than 16 millimeters if it is tricuspid, more than 19 millimeters if it is a bicuspid valve. We are talking about at the functional curvatures. So the geometric height greater than 16 if tricuspid valves, greater than 19 millimeters in bicuspid valves may be suitable for repair. To conclude, the aortic valve and aortic root are very complex circuits. They are certainly not simple. The success of repair depends on the echocardiographic findings, and the language spoken in the tape across the screen should be common in the sense that we should be able to communicate across the screen effectively and mention the correct, correctly communicate across the screen. And of course, the systematic analysis of the aortic root and valve apparatus by PE on table is of invaluable help. There's a bright future because this is associated with long-term good, excellent long-term results. Thank you so much. And now I request Dr. Prasanna Simha to give us the surgical input in this matter because it's a very interesting topic. And I'm grateful to Dr. Prasanna for being with us. Dr. Prasanna.
Thank you, sir. I'll share my screen.
Yes.
Is it seen?
Yes, we can see.
Yeah. Good morning, everyone. I'm talking about the surgical principles of aortic valve repair. There is a problem with the analysis of the aortic valve because the aortic valve achieves competence at multiple levels. Analysis of each component is required, and intra-op analysis is initiated by the absence of distension when we are doing the surgery. The zone of coarctation is less than the mitral valve. And another important problem is visual intra-procedural testing like saline testing is not available to make micro adjustments. While doing a mitral valve, you can put saline, see there's a small leak, but that's not so. There are attempts, a lot of people are trying to make devices to help it, but none of them are really consistent in their this thing. And so this has been the bane of mitral aortic valve repair. So not many people attempt it. Now, the things which I tell on a practical basis is calcified valve repairs are best avoided, especially if you have a focal area, you can do it, but significant see, the history should not keep repeating itself. Aki Senning in the 1960s used to decalcify valves and then repair them, and then they found that in a very short time they would come back. So it's not advisable to take significantly calcified valves. Mixed valvular lesions are again difficult to repair because valve retraction is a significant problem. This becomes an issue, especially in children where you want to preserve the valve, where you might have to bend this way and that way. Pure regurgitant valves, both bicuspid and tricuspid, are repairable. The leaflet quality should be the final determinant, as unexpected things like stress fenestrations may preclude repair. This cannot be made out commonly on preoperatively on echocardiography because the stress fenestrations occur in the lesion of coaptation. There are arguments for and against it, but sometimes it is so thin and tenuous that it may preclude repair. So the final decision is always taken on table. I would like because there are significant amount of students here, this is the article that everyone should use for nomenclature and classification of congenital bicuspid valve. And this position statement is a mandatory read for every person doing aortic valve repairs, dealing with aortic valves of whatever nature, be it replacement, repair, or anything. I would invite everyone to go, the students to go and read this. Now, already Dr. Muralidhar has mentioned all of this, but please remember it's a three-dimensional structure, and unlike the mitral valve, we have to deal with every portion of the complex. Remember, it is a coronet or a crown, and it's very important that we remember that we have to correct all the aspects of the crown. Deformation can occur in every place. Again, I will draw your attention to geometric height, effective height, coaptation, which Dr. Muralidhar Kanchi has already told. This is very, very, very important because this is the cornerstone of the repair. These measurements help you to, because we don't have a saline testing, many of these things are going to be used, and I will show you how we are going to measure these intraoperatively to help us get a better repair. Now, I will always try to give the for a surgeon and for the cardiologist and echocardiograph and the cardiac anesthesiologist. Please remember that the cusp is like a suspension bridge, and when the bridge tip moves towards each other, the thing sags. This is just like the coronary. I'm sorry, the cusps, and if it moves away, it goes up, but again it causes a leak. Similarly, when it moves towards here, again the cuspal height goes up and the cusps move away from each other. If it moves out like this, the cusp sag. This is the problem that is occurring in aortic valve repair, and everything revolves around the suspension bridge problem. You are trying to make everything become vertical. And so you have 1, 2, 3, 4 problems to deal with at 4 different levels, both of which can cause one thing going up or down. Up will be retraction of the leaflet, down will be prolapse of the leaflet. And the same thing has been told by many, they say, and here you can see that if the geometric height increases, and that is the goal in aortic valve repair, the coaptation goes up. If the basal ring goes wide, you get shortening and leak. And similarly, the sinotubular junction becomes wider, you have again shortening and a leak. So you need to manipulate all the 3 components here to be able to get, this is a very, very important diagram by Maran et al. And I would recommend people to go and read this article. Now, the measurement of the leaflet length is very important because this gives you an idea of how much you must do, what are the things that are the problems that you are going to get. Because see, the standard measurements are there, but very important that you take these measurements. And I commonly write this down. I write in my transthoracic echo itself, when I'm going and analyzing these patients, I need to have this. This also gives you an idea of what is the STJ. If the STJ is wide, the leaflets are short, you're going to have things. So there are multiple things that can be got from this. These things should be generally symmetrical, and then you can get an idea of what is the prolapsing leaflet. These are in addition to the regular measurements. Now, the first thing that we commonly do is it a bicuspid or a tricuspid valve? Non-calcified bicuspid valves who are prolapsing are far more easy to repair because it is a planar single line of coaptation that is occurring. But tricuspid valves, I'm sorry for the spelling mistakes, have to be assessed one leaflet at a time. And another problem is that the interaction with the other leaflet also has to be thought about when trying to do these repairs. Now, I will not go into this because Cowrey's modification of Carpentier's tracing is very, very important. And this is important because it helps us to analyze in a structured mechanism, how is the valve leaking? Now, when we come into the surgery, we've gone on bypass, given the cardioplegia, opened the aorta. Now, how do we assess? You are having a flaccid valve. And so what we do commonly is we take a stitch on each of the tip of the noduli aurantii, and we try to, and we pull it. This is described by my mentor, Dr. Robert Frater, who passed away recently. He's one of the pioneer cardiac surgeons in the world. And he described what is called as the Frater stitch. And when you take this, you can see then that you can find out if a leaflet is more prolapsing, not prolapsing, and other things. Similarly, the sinotubular junction and annulus have to be side with height agars or various other devices. Another thing, the trick that we can use is put the LV vent on, and then put central suction with a fine suction catheter, and I mean with the suction, Yanker suction with the tip removed. And this causes the leaflets to get sucked inside. And this can help determine which is the leaflet which is prolapsing or which is retracted. All these things can be made out. These are all ways to try to determine things, because we don't really have anything to distend. So we try to suck inside. So these are the things, unfortunately, that can be used. Another thing that we do is we have to use calipers. Now, I don't have Schaefer et al. Described certain calipers, but I never had access to these. So I made my own calipers, and these are the calipers which I have got it recently 3D printed. I used to cut it in plastic, but these are the ones which I have designed. Now you can see two numbers here. I hope you can see there is called there is a 9 and there is a 15. 9 refers to the geometric height, and the goal is actually that you should always have a geometric height of 8. So I have kept 9 as my target, so that even if there is a little shortfalling, you're always going above 8. And 15 refers, 9 refers to the effective height, and 15, 17, 19 are referring to the geometric height. Why in a tricuspid valve we'll have 17, 19, but because I do a lot of pediatric repairs also, so, and the pressure is also a lot to repair pediatric valve. So these are the ones which are being used for tricuspid valves, and these are the ones 22 and 24 are what is for what is for bicuspid valves. Now, when you see this, I don't know if my arrow is seen. Is my arrow seen?
Yeah, we can see.
Now, how is this designed is that this curve which you see here down refers to the geometric height, whereas the height from this knob which you can see here refers to the will give you the effective height. And I have actually, I don't know whether you can see, but I have put millimeter markings. These were 3D printed in my house, incidentally. I have made it and designed it with the help of my son, and we 3D printed it. Previously, I used to make it with plastic sheet and cut it and use it. So this can help you measure how much shortfall you have of the effective height when you place it in the sinus. Each of these is put into the sinus, I mean into the, it abuts the leaflet, and when you push it down, the leaflet sags, and you can measure how much is the shortfall which you need to correct. This is my modification. Now, according to coverage classification, you can go according to that, you measure everything. Now, one of the things that you can have is a perforation. This is one form of DESIC. And it's one of the easier ones to DESIC. If you have a perforation, you can patch it. Please remember one thing. If you see a perforation here, please check the mitral valve, because you can have a drop lesion on the mitral valve because the jet goes and hits the mitral valve. And if the jet is hitting the mitral valve, you can have this thing. So it's very important that when you're assessing the aortic valve, please don't forget that you have to assess the mitral valve. Also, AR can cause function dilatation and regurgitation. So always a comprehensive analysis of all the valves should be done. Now, the next thing is in prolapsed leaflets like this, you can do this triangular resection, which is there in this picture, is no longer commonly performed. It has been found to have a higher dehiscence rate. Rather than that, as you can see here, I have plicated the thing. So leaflet prolapse is done commonly by what is called as a central cabral plication. And you can see in this case, central cabral plication being done to relieve cusp prolapse. The other method which is used is called as a Trussler repair. And Trussler repair is taking the redundant leaflet, as you can see here, and suspending it up and through with a pleated suture up the valve. So the specific, I use this less often than central plication because central plication is symmetric. But sometimes when the leaflet is sagging, and you may add this to allow the coaptation, the whole leaflet edge to move up. So lots of tips and tricks have to be used according to the need of the case. And then when you want to increase the coaptation height, you can have what is called as Cabral. Cabral was a surgeon who did a lot of work on this. And here you can see that this is called as subcommissural annuloplasty. So actually the leaflets are plated sutures are passed on either side. And then when you put it, you can see that the coaptation height comes. So each component, and that's why the echocardiographic assessment is very important, and intraoperative assessment also is very important because these gives clues. I always say repair has to be planned before going into the operation theater. Then as soon as the TE is done, you have to modify any new information that comes. Remember, the fallacy of TE is that the afterload condition can vary so much that don't take the indication for surgery. The need for surgery should never be estimated on the intraoperative thing. I see many times we will assess this on TE during surgery and we will take a decision on ischemic MR or these sort of thing. No, those things must be done with before anesthesia. The need for surgery has to be determined before surgeries. Do not determine the need for surgery for that particular thing at the time of surgery under anesthesia. Now, isolated ST junction dilatation does not require, if the root is not, the sinuses, the other things are all normal, but only the ST is wide. Simple as this patient, for example, had had AR, but we did nothing for the thing. All that we did is we replaced the ascending aorta with the appropriate size tube graft, which caused the ST junction to become narrowed, and the AR disappeared. So this is called the wheat procedure, and here you are correcting it by just ST junction manipulation by replacing the ascending aorta. This is another case. See here, you can see the subcommissural annuloplasty has been done. You can see central plication can be done. This is a patient with VSD grade 4 AR kit. I will like to tell every echocardiographer here that if you have a VSD with severe AR which requires an aortic valve replacement, it is a failure of our medical system. So there is no such thing as spontaneous closure of a VSD. Outlet VSD is never closed, and so an outlet VSD must always be sent for closure. And if you are getting AR, we have failed our duty as doctors in this country. But it happens and happens regularly. Then, when we have multiple levels of dilatation, it cannot be done in by just correcting one point. And in this type, we need to typically do a David procedure. So you can see here we have done 2 cases of David procedure. And here we are basically doing a reimplantation. We are putting the entire valve and the root inside a tube. And this is where measurements are very important, because the annular measurements and the thing, because the surgeon will be guided both by intraoperative by measurement, but also by the echocardiographic measurement. What is the size of the tube graft that he is going to plan? And I will show some the pictures afterwards. I mean, in the video little later about how things can go wrong and how it was done. So this is the definitive operation for many of the patients who require extensive multi-level correction. Here you can see a bicuspid valve which has undergone again this procedure. Here you can see Gore-Tex Corday is CV7 is reinforcing the leaflet, and actually there was stress fenestration which was supported by this. You can see here both the leaflets were prolapsing. So you make in bicuspid aortic valve, you make one leaflet, you correct one leaflet, and the other leaflet is matched to it. Please remember that, see here, you can see that the coarctation point should not be sagging. What I call as a sagging bottom should never occur. Those will give initially a good result, but then will fail in short while. I will show that. This is an example of a case where you can see already Dr. Muralidhar has told. So we are seeing here different views, and you can see that there is a significant amount of AR. But I want to tell you that under anesthesia, see with load manipulation, if you look here, it looks far less than what it looks through this view. So multiple plane interrogation is very, very important, and under proper loading condition. In this case, it was under there was some amount of hypotension due to some reasons, and the patient also was vasodilated. And you can see that the AR is looking far less than what it was looking, which was like this. So very, very important to have your loading conditions right. And this is just to give this in, this is an example of a patient where you are having again the David procedure being planned. You can see this is a bicuspid aortic valve. This is the same case which I'm just showing there. And you can see we have dismantled the root. And I want to show one thing. Can you see this, that the left main orifice is extremely close to the commissure? And this particular case, we had this is some information which you have to also try to provide to the surgeon. How close is the coronary ostia? And in this place, when I was doing the David, At the end of the procedure, I had a very difficult time detaching the coronary artery, but we did it. And there are techniques to avoid it also. And then afterwards, I had to put a Cabral graft. You can see the Cabral graft going there because the coronary artery was banged at the point of the commissure. See, whatever we had it just next to the commissure, when we did the repair, the coronary button would be at kinked in any other position other than at the point where the commissure was. So it would have been an impossibility. So we put it round and we brought it with the single Cabral graft, RCSS. So a lot of the information can be provided by the echocardiographer here, and the surgeon must be cognizant of all these problems and plan. So at the end of the surgery, we should see that we are having a good effect, see, geometric height is what the patient is born with. And the effective height, you can see here is, there is a good effective height of nearly 10 millimeters. The coaptation is actually very good. There is a small trivial jet. This jet actually is hardly seen on transthoracic airway, but you can see that it is a symmetric small jet, which is just there. Problem in Indian patients is many of them come at a very late stage with thicker edges, and when we do this coaptation, we may end up with some amount of leak in the center. One my associate professor said, why do we get sometimes this thing like this? I said, see, our leaflets are end up with a thicker leaflet where we do leaflet shaving, giving, and all those sorts of things, because the area of deformation is much more, because our patients are referred far late for these things. But then we get this, but these things are very stable if they are symmetric. Another very important thing is, can you see the tube? Now, if you see the edge of the tube, and I will show the picture also, you can see that the bottom of the cusp is not below the lowest point of the tube. This is a very, very important thing, because, and what I call as the saggy bottom. If you have the saggy bottom, it will not last long. And actually, Tyrone David, in a recent article just done a few weeks back, I will show you the thing. This is a very important point. If you don't do this leaflet, pressure on this leaflet, the stress will be more, and that leaflet will, again, if you have saggy bottom, it will be like going like a small baby falling into the toilet, a Western toilet. The bottom is saggy and you will sag into it. So here you can see, very important to see that the gradient is good. And I will tell you that when you do aortic valve repair, you have to be careful, especially in that you don't cause aortic stenosis. And you can see a single digit gradient is there. And this is what I was telling, that this is the article by David recently, and I would recommend people reading it. I will give the link later if required. But it's very important that you don't have the saggy bottom. That is, when you do this, you must also have a minimum value of effective height of at least 8 millimeters. That's why I keep the target as 9. And the coaptation should be 4 millimeters. Now, see, remember that we want a centimeter in the mitral valve, but it's 4 millimeters target for the aortic valve. But still, I would say aim for a better value. You can see here you got 1 centimeter nearly. And this is a case where somebody in one of my colleagues had done a David, and then he called me saying, sir, can you have a look? And it wasn't, unfortunately, I'm sorry, but what happened is the person tried to, the company fellow tried to service, and he deleted most of the things down. But I will show you what happened. He came, and then when we did the pressurization test, what I do is we put a balloon and then pressurization test. When he called me, and I showed, see, this looks like a saggy bottom and it's down. So I was called in after most of the surgery was done, and to assess the quality of the repair. And then I said no. Then we put a Foley's, and we put the Foley's to occlude the graft, and we gave cardioplegia, and then there was a torrential AR. So then now I was called in at this stage, and I was asked to do something about it. So what I did is I had to re-repair the valve with what was the procedure done, and I'll show you the ring afterwards. See, you can see there is a central leak, and actually the VC was early to 2 millimeters. Unfortunately, and you can see that now the leak is a central leak. It's a little. Can you see that leak is a central leak? There is some acoustic shadowing and other things, but but we had to go back and see. I did not allow it was something of 2+ would have been my estimate of the AR, but don't accept that. Can you see that it is there? It's very important that you get. It was slight eccentricity, but I accepted it because the origin of the thing was extremely narrow. And you can see here, actually, it is quite central. And and then I'll see, this is how it was. There is one frame showing how it was before the correction here. And this was all these things. There's a little bit of an error in this when they have sent. And do it with good hemodynamics. See, if you have bad hemodynamics, it's usually this a bad thing. And unfortunately, many of the patients come with the significant amount of AR2, I mean, LV dysfunction. So be careful as I say. Now, so it's very important to not accept error, go back in and do the things. Another common cause of which we get is subaortic stenosis with secondary AR in India. Because they've come late, typically they have leaflet adhesion and prolapse or retraction, and there can be jet damage. And these require excision of the subaortic stenosis and repair of the leaflet. It may even need patching, and the leaflet may get actually othered to the subaortic membrane, and you have to carefully peel out the membrane and do all those things. And you can see that we can do successful repair in these patients also. VSD-AR, can you see, this is what I call the failure of our medical system. This should not happen. And you can see the complex repair that was required in this kid to prevent aortic valve replacement. Aortic valve replacement would be a disaster in a young child. They don't survive. Because however much we may send them alive home, but they don't live. So I have spent hours trying to do this. In fact, we have had to even redo. People have closed the VSD, and then I have had to do that. And so you can see here the VSD being corrected. Here you can see central plication, subcommissural annuloplasty. A lot of things are here. So this is an example of a redo VSD-AR where what has happened is they have closed the VSD, but during the closure of the VSD, the bite has been taken into the aortic leaflet, and it has cut through. The VSD is there and AR is there. I get a lot of references for these sort of patients, and it is challenging, but we have to sit and re-repair this cell, patch the hole which has been created, and close the VSD again. So again, bicuspid aortic valve, I've shown you this thing. Very important in the post-operative to put them on lower sartan. And in elective cases, if there are large aneurysms, elective debranching may also be required because these patients may be in future, especially Marfan's. Point to remember is freighter stitch. You may need trustless repair, cabral central plication, subcommissural plication are there required, ST junction restoration. David procedure is important. The zone of coaptation, I would like to add, avoid a saggy bottom, and all these things are there. Intraoperative tests, suction test with venting. The root cardioplegia, another thing that it does give root cardioplegia. If you cannot get a pressure of 100 to 150, in fact, I tell the perfusionist, can you generate a root pressure of 150 if you can, while giving cardioplegia? If you can, if you have, when you're towards the end of the repair, when the aorta is closed, I always give cardioplegia. If you cannot get, I'm more strict now, 150 pressure at the pump head, that comes to around 60 pressure in the root. If you cannot generate it, your repair is bad. At the same time, get the echo done while cardioplegia is going on. If the vent, step up the vent. If it is more than 10% of pump flow, for example, if the flow systemic flow is 4.5, if the then if it liters, then 450 ml if you are getting that, AR is more. The TE or epicardial echo with good hemodynamics, and remember, don't convert AR into AS. So in conclusion, AV repair can be done in selected cases with good valve morphology suitable for repair. The silk sets needed are higher due to need for multi-level correction. Testing is more post hoc, so fine adjustment is more difficult. So try to get everything done right at the right time. Coaptation plane of 5 mm. Tyrone David is now saying 4 mm is good, but I always say target 1 millimeter more, and you will end up with much less effective height. Aim for 9 mm and 5, and now Tyrone David is saying 8 mm and 4 are good, but go for the higher value. Eccentric residual jets to be avoided. You need a good appreciation of 3D orientation of the aortic valve. Good pre-op planning with meticulous intraoperative echocardiography is the cornerstone for being able to do the repair. Thank you.
Thank you, Prasanna, for that excellent presentation from the surgical point of view. All your points are well taken. You stress that the coaptation length should be greater than 4 millimeters and effective height about 9 millimeters for a successful repair. And also you mentioned that the loading conditions must be fulfilled when you assess the aortic regurgitation. The decision to take-up for surgery should be done much before the actual surgical, until on the table decision, etc. Thank you very much, and we actually learned a lot from you. Any questions are there? Please feel free to either unmute yourself and ask or put it in the chat box. Dr. Raghu, you have any comments to make?
No, sir. It was a nice talk by sir. And many times when we do repair, I was always thinking when you have a conduit, it is very difficult to see the effective height or the coaptation height because there will be hyperechoic shadowing on the leaflets. So always it is better to see in transgastric view to overcome the. And many times, most of the times, our echo measurements will be equal to their caliper measurements. 99% of the time we got the same measurement as what their caliper was showing. To overcome this aortic insufficiency after repair, if you have an AR, it is always better to see in multiple views and assess. One view will not give immediately after cross clamp release. If you look at the echo and see some jet is there, it will not show us properly. We have to get it we have to completely off CPB, and then you have to assess the valve to have to see where exactly the leak is coming. Rest of the things was answered.
Yeah, and I can make one point there. There are two things that happen there. I fully agree that multiplanar views are to be done for assessment. The other thing that happens is sometimes on CPB where you'll have a particular looking jet, but when you are fully loaded again, when the leaflet stresses, when the leaflets are stressed together, the things may change again. So the final decision is when when you are just release the clamp, you get some idea. But the final thing is when you fully load and do the assessment. I agree with you.
Yeah, absolutely. You're right. You're right. It should be under
One
full
more thing
loading
I just wanted to, one more thing I just wanted to add is once the repair is done, once you are come off bypass, you should always check the leaflets are not hitting the conduit. If it is hitting the conduit, there is more stress on the leaflets and it goes for degeneration. Always the leaflet should not touch the conduit. That is what in echo we have to assess on M mode in the mid-esophageal long axis. Put a M mode on the leaflets and you can see the gap when the leaflets are open during completely systole. That is one thing I just want.
Yeah, one point I would like to make surgically is that if your leaflet is hitting the conduit, your sizing of the conduit is too small. And this is a common error that people make is that you use a very small conduit. Remember, I always tell everyone you can always put tucks on the conduit. You can narrow the conduit by putting later if required, but never ever take a small conduit, especially because for financial constraints we tend to use a straight conduit and we don't use the Valsalva graft, which is more expensive. So when in these situations, always use a bigger conduit and you can narrow it down at the sinotubular junction and you can put tucks on the ST junction, but you can do all that, or you can put an additional tube or whatever. But the commonest error is using too small a conduit if it is touching the conduit.
Thank you for that input, Raghu. That was a good point
I
about
have
leaflet should
one
not touch
question,
the conduit. Yeah. Please, Srinivas.
Dr. Srinivas. And for Dr. Prasanna,
Yeah.
is there any role of the ST junction? You said the ST junction reconstruction.
Yes.
Like especially the echocardiographic, some of the points mentioned is the ratio of ST junction diameter to annular diameter more than 1.3.
Yes.
Probably you may have to do some reconstruction of the ST junction because there will be effacement of the leaflets.
Yes. I gave just as an example how we actually did nothing for the rest of the aortic valve, but only did the Wheat procedure. That was because the ST junction was abnormal. And we did the ST junction adjustment. As I said, all three levels, the ST junction, the sinus morphology, the coronet, the virtual basal ring, all of them have to be addressed. So if you don't do that, you will again have dilatation further and it will cause central AR.
One more query is there any role of the geometric height Like we have described the effective height and the cooptation height of automation is 4 and 8. What about the geometric height?
Geometric height in adults, if it is less than, if you measure if it is less than 15 or 17, it doesn't, it's essentially telling
After
it's
repair,
a leaflet retraction. But the problem is that we are doing in a lot of kids. So in that time, what you have to do is take a call on the, what I do is I take the free margin length and take the call according to that. So in that case, you might have to make everything smaller, right from basal ring, the thing in the kids, you might have to make everything short. But in adults, if it's a retracted leaf, what are we telling when we say the effective height is less? Is essentially we're telling leaflet retraction is occurring.
Okay.
So those are the ones you are not going to repair. Or you have to, the other option which I do now is I do that leaflet, I do a Ozaki for that leaflet and repair the other two.
Okay.
Or I have just done sometimes is I have taken the pulmonary leaflet and auto transplanted that particular leaflet which is retracted and done all that sort of circuit. But that's all more in the younger patient where the pressure to repair is more.
Yeah. One more query about the trustless repair. What's the long-term outcome? Because previously in our institute we used to do a lot of trustless repairs, especially in congenitals. But of late, I think the incidence of long-term AR is not very encouraging because we are with the redundant leaflet only one. Only one leaflet you are retracting and making the commissioner this thing there.
That's why I mentioned that I don't do. I used to do more of trustless, but I have shifted more to Cabral central plication. Number one. Okay. The only time I do now a trustless repair is in conjunction with the other procedures where I want to lift up the whole leaflet. As I want to see some of these patients at the commissure, there is a sag at the level of the commissure on the eccentric sag. And if you find typically if there is if that eccentric sag is there, you do the central plication and then you try to lift up that other point. That's what I do now. I don't use trustless as much.
Resuspension.
Yeah, it's sort of a resuspension, but you have only one leaflet at times when you need to resuspend, and that leaflet will be resuspended at that point.
So in which case you do the subcommissural annuloplasty?
I do
mentioned that 4 fulcrums are there. Like if you even if that also is dilated, the below the VA junction, that also may create the postoperative aortic leak. So in which cases
it's where the subcommissural annuloplasty, when you are going to do that, you're trying to do it when you want to increase the coarctation height when it is sagging, and you want when the virtual basal ring is also slightly wider. So you take the call on that. Basically, the coarctation height you feel is the virtual basal ring is coming down, but this is typically done more in kids. In an adult, it would end up more with a David at that time.
Murli sir, I have one query for Echo.
Sure.
This usually the distance from the aortic annulus to the LCA orifice is not well seen in 2D views. Usually they describe 3D echocardiography with the deep transgastric long axis view to measure the distance between the annulus to LCA. Is there any 2D view where we can get this? Because I tried in many patients, very difficult to see the LCA orifice. Once you get a 3D volume, you can crop and you can measure the distance from annulus to the LCA. RCA is very well seen, but LCA is very difficult to see.
LCA is difficult to see actually. RCA is somewhat better, easy to see. That is true. I actually have not tried to look at this measurement in 2D. Raghu, do you have any idea about this? Distance between annulus to the LCA, is using 2D?
Sir, not in all cases we get. In few cases, in short axis view, if you just move your probe from the short axis mid-esophageal AV view slightly upper, you can see the opening of the left left hand, and put it and explain and open that. So at perpendicular, you can see. Sometimes we can get it, sir. Not in all cases, I feel.
So you require explain or some 3D view for but 2D views, classical 2D 28 views, they haven't described the distance between aortic annulus to, because most of the time for TAVIs and all, the CT scan itself will mention about the CT protocols will mention about the distance between the annulus and the LCA origin. That's one of the limitation of 2D.
What Raghu said makes sense to me. I think I'll try it out next time. Any other questions? We are running out of time. Actually, we have crossed the time limit. Any the last question or comment? I think we have come to the end of session. I would like to thank you for joining us. It was an excellent session on the aortic valve repair. And we have gained some knowledge regarding this because of this interaction. And thank you, Dr. Prasanna, for joining us.
Thank you very much.
Srinivas.
Thank you.
And before I conclude, do you have a video of the
Yes,
group,
sir.
sir?
So,
Can you play that
so
video?
before concluding, just allow me
Yes.
some time to play the short clip.
Yes. Please join us for IACTA T 2024, August 21st to 24th. It will be done at Narayana Vidyalaya, Bangalore. Thank you so much, and looking forward to seeing you next Sunday, and have a great Sunday. Thank you very much.
Thank you.
Thank you so much, everyone, for extending us the opportunity to host the session. So, with all your permission, I would like to conclude the session over here and looking forward to host you again. Thank you so much. Have a
Thank
great
you.
day.
Thank you.